Hi everyone, I'm Erman Akkus from Ankara University Faculty of Medicine, Department of Medical Oncology. I'm happy to join in OncoAlert Colloquium and happy that you also join us. And in the next 15 minutes, I will present how I treat GI cancers with limited options in resource-limited settings. My presentation will be on practice-changing trials in 2025 and will include NCCN guideline algorithms and put the contexts. And I will comment on how to approach in limited resource settings in these practice-changing trials. So my presentation will include colorectal cancer, to esophageal gastric cancers, hepatocellular carcinoma, pancreatic and biliary cancers, and finally conclusions. So let's start with colorectal cancer. The first trial is that in the colon cancer early stage is ALASCCA trial. In this trial, stage 1 to 3 resected colon cancer patients will be was screened for PIK3 kinase mutations, alterations, and PTEN alterations. And then after standard adjuvant treatment, the patients randomized to aspirin versus placebo. And in this trial, the recurrence-free survivals and disease-free survival was significantly improved by aspirin, adjuvant aspirin. And in NCCN guideline, after our standard approach based on stage and risk factors, and the aspirin is recommended for PIK3 kinase mutated colorectal cancer patients. But in practice, the testing for PIK3 kinase cannot be accessible, or maybe it's also it's not cheap. So when we look at the American College of Cardiology recommendations, they suggest that the primary prevention of cardiovascular disease can be performed by aspirin in patients with from 40 years old to 70 years old and who had high risk of cardiovascular disease but not at increased risk of bleeding. So in my opinion, in patients with diabetes, hypertension, dyslipidemia, obesity, and smoking, and under age of 70, if there is no bleeding risk or other contraindication, it may be reasonable to start aspirin, if not receive already, without PIK3 kinase testing. Another study that we see in this year as a practice changing is challenge trial. After adjuvant standard chemotherapy, and the structured exercise is improved the disease-free survival and overall survival in patients with colon cancer. So it's also we should utilize this strategy in resource-limited settings for our patients. And another study in the early stages in colon cancer was niche and atomic trials. In niche 2 trials, we know that there is a single-arm phase 2 trial in stage 2 or 3 colon cancer patients. The 2-dose nivolumab and 1-dose ipilimumab was applied in neoadjuvant setting without adjuvant treatment in deficient MMR colon cancer patients. And in this year, in ESMO, we have seen an indirect comparison with Foxtrot trial, and this neoadjuvant immunotherapy strategy was superior to chemotherapy in these patients. But on the other hand, in this year, we have seen the atomic trial in stage 3 resected colon cancer deficient MMR patients. Adjuvant FOLFOX combined with atezolizumab provided significant improvement in the DFS. So there is no data which strategy will be better in these patients. And in the NCCN guidelines, the neoadjuvant immunotherapy strategy is recommended for T4B and bulky nodal disease patients and local unresectable disease. And also in the stage 3 patients, the FOLFOX, the chemotherapy plus atezolizumab is also recommended for the adjuvant setting. But in the resource-limited settings, in stage 3 deficient MMR patients, maybe for stage 2 too, after discussion with the patient, I think we can offer self-coverage, self-paying 2-dose Nivo and 1-dose EP may be offered for our patients because atezolizumab is applied for 1 year for these patients. So another practice-changing trial was the Breakwater trial in the metastatic setting for BRAF mutated colorectal cancer. Ankara fenebrutinib combined with FOLFOX in the first-line treatment of in the first-line treatment significantly improved the overall survival around 30 months. And NCCN is also included in as an initial treatment and in BRAF mutated patients. But I would like to, so encorafenib may not be indeed accessible, and sometimes we cannot access the encorafenib in our country too. But what I would like to show is that there is some phase 2 and retrospective data that chemotherapy triplet plus bevacizumab provides around 17 to 24 months overall survival in these patients. So in BRAF mutated colorectal cancer, when encorafenib is not available, if the patient is fit enough, I think we should utilize triplet chemotherapy plus bevacizumab. And the second line and subsequent therapy of metastatic colorectal cancer, we have fruquintinib, regorafenib, TUS, beva, and other targeted treatments in the portfolio. But sometimes these targeted therapies and the other agents are not accessible and available in the resource-limited settings. But what I would like to emphasize that the chemotherapy rechallenge and regorafenib chemotherapy rechallenge and reintroduction may be an option always in our patients. It's not that uncommon. Patients are still fit enough for the chemotherapy after several lines of chemotherapy. So considering existing toxicity, performance status, and previous response and disease control, I think rechallenge of chemotherapy is an option for our patients. Another study that's practice changing in the 2025 was podium trial in metastatic anal cancer. It investigated retifanlimab combined with carboplatin paclitaxel in the first-line treatment and showed significantly improved progression-free survival and overall survival in these patients, and become the preferred regimen in the NCCN guideline. But retifanlimab may not be easily accessible for our patients. When we look at the subgroup analysis, it shows that in patients with 75 years old, under 75 years old, in female patients and liver metastatic patients and PD-L1 positive patients may be more beneficial. So in this patients group, we can insist on to access the treatment. So let's move on to esophageal and gastric cancers. So we already know that the Checkmate 577 trial in the adjuvant treatment of esophageal and gastroesophageal cancer. So in this year, we have seen the final overall survival results of this study in esophageal and gastroesophageal squamous and adenocarcinoma after chemoradiotherapy and surgery in patients with residual disease. Adjuvant nivolumab for 1 year was applied in this trial. So overall survival is significantly improved. It's okay in the squamous cell carcinoma. It's already accepted as a treatment in squamous cell carcinoma. But in adenocarcinoma, the NCCN guideline also includes as a category 1 recommendation if the perioperative chemotherapy is not chosen and if the initial therapy is chemoradiotherapy. But when we look at the overall survival subgroup analysis in this year in the results, that it's not that significant in the adenocarcinoma subgroup and also in the PD-L1 negative group. So we have a Matterhorn trial, which I will mention later. So we have better choices for adenocarcinoma. So based on this overall survival subgroup analysis and the alternative choices, I wouldn't insist in adenocarcinoma in resource-limited settings after chemoradiotherapy in patients with adenocarcinoma. But in esophageal squamous cell carcinoma, after chemoradiotherapy, if R0 rejected and if there's a residual disease and CPS positive, so I will definitely consider adjuvant nivolumab. So the Matterhorn trial, as we know that the 2 doses preoperative durvalumab and surgery with float and surgery, and then durvalumab continuation in the adjuvant setting. So we already have seen the EFS results of these patients, and also in ESMO we have seen the final overall survival results of the Matterhorn trial significantly improved the overall survival in these patients. In NCCN guideline, float plus durvalumab is recommended for CPS positive patients, but the FDA approval was regardless of PD-L1 status. But in this study, so very low number of patients were included as PD-L1 negative tumor. So when we look at the overall survival key subgroups, so it's in the clinical lymph node negative patients, it doesn't look like very beneficial, and in the diffuse cancer type, it's not like benefit. So in my opinion, that in the PD-L1 positive patients, in lymph node positive patients, clinical lymph node positive, and if it's not diffuse type gastric cancer, at least 2 doses of preoperative durvalumab may be recommended by self-coverage of by patient itself, because to evaluate the chance of and assess the chance of complete response in these patients if durvalumab is not reimbursed as in our country. So the other trial was in the gastric cancer in the metastatic setting. In the second line, Destiny Gastric 4 trial, trastuzumab deruxtecan was compared with ramucirumab plus paclitaxel, and the trastuzumab deruxtecan in HER2-positive patients, the trastuzumab deruxtecan improved the overall survival significantly, and now it's in the category 1 recommendation for the subsequent line and second line and subsequent line treatment of gastric adenocarcinoma. But trastuzumab deruxtecan may not be accessible also in a resource-limited setting, but I would like to show some data that the trastuzumab beyond progression in HER2-positive gastric cancers may be beneficial in for our patients, especially when we consider trastuzumab beyond progression in breast cancer and bevacizumab beyond progression in colorectal cancer. So it may be considered, I think, in patients with gastric cancer when trastuzumab deruxtecan is not available. So when we look at the hepatocellular carcinoma, in this year we have seen several studies becoming standard of care in the first-line treatment of advanced hepatocellular carcinoma. Nivolumab plus ipilimumab showed significantly improved overall survival, and we have seen 5-year OS results of Himalaya, durvalumab, tremelimumab, and we have seen camrelizumab plus rivoceranib in the first-line treatment. So atezolizumab plus bevacizumab is generally accessible in most of the countries, but if there is a contraindication to bevacizumab, and if the double IOs are not available, still TKIs are options. And in this setting, I will suggest lenvatinib rather than the sorafenib as a first-line treatment in patients with advanced hepatocellular carcinoma. When we look at the pancreatic biliary cancers, and in the advanced pancreatic cancer, we have options that FOLFIRINOX, gemcitabine, nab-paclitaxel, and NALIRIFOX. Indeed, in the previous year, we have seen the NAPOLI-3 trial that shows NALIRIFOX is better than the gemcitabine nab-paclitaxel in the first-line treatment, but we didn't know whether FOLFIRINOX is better than the gemcitabine nab-paclitaxel or not. So this year we have seen 2 studies, PES and GENERATE trials, comparing gemcitabine nab-paclitaxel and modified FOLFIRINOX in these patients, and although the differences are quite low, these 2 studies suggest that the gemcitabine nab-paclitaxel in the first line and treatment is maybe more beneficial, probably because of the FOLFIRINOX treatment and similar chemotherapies after gemcitabine nab-paclitaxel. So but nab-paclitaxel is also not always available, and it's not cheap compared to paclitaxel. But we have a data in the second line setting. After modified FOLFIRINOX in the first-line treatment, gemcitabine paclitaxel, not nab-paclitaxel, was investigated by Italian colleagues, and gemcitabine paclitaxel was associated with the improved PFS and response rate. So, in my opinion, that gemcitabine paclitaxel may be considered in appropriate appropriate patients in after modified FOLFIRINOX, or even maybe in the first line if nab-paclitaxel is not available. So another trial was the zenotuzumab trial study in pancreatic cancer in NRG1 fusion positive cancers. So although this is a single arm study, the response rates was promising, and it becomes an option in the treatment portfolio, but already in the guidelines, and we have seen this study in this year. So finally, biliary tract cancers, we have seen the 3-year OS results of TOPAZ study in this year. And at the 3 years, we have seen that the OS rates is almost doubled by adding durvalumab. And as now, durvalumab plus gemcitabine cisplatin or pembrolizumab plus gemcitabine cisplatin is the first line choice in advanced biliary tract cancers. But if the IO is not available, so gemcitabine cisplatin is still an option. But in the second line, the FOLFOX chemotherapy is for all comers, but FOLFIRI is another choice. But the targeted therapy portfolio is significantly improved for biliary tract cancers. Even this year, we have seen tinangotinib, which is efficacy, which has efficacy in even in patients pretreated with previous anti-FGFR treatments. So, but these targeted therapies may not be accessible to or reimbursed in most of the countries for our patients. So for generally, my final message for the research limited setting is that always we should consider a well-designed and appropriate clinical trial for our patients. So finishing my presentation in 2025, we have seen a lot of practice-changing trial from adjuvant treatment to the first line and second line treatment of metastatic setting in the in gastrointestinal cancers, and we have seen new targeted treatments in the portfolio. But there are a lot of candidates for future practice-changing strategies in gastrointestinal cancers, and we will see the study results, I think, in the next year. So thank you so much for your joining and listening, and I'm happy to answer any question and listen to comments. Thanks so much.